Hi, I'm Ganesan Abu. Hello and welcome to this series of three presentations. In part one, I will look at the new sepsis definitions and clinical criteria and examine why we needed this change. As regards all the presentations, I wish to declare that I do not have any conflict of interest. What's in a name? A rose called by any other name smells just as sweet. Perhaps it's the color or the texture, or maybe even its thorny stem. But we all know that a rose is a rose is a rose. But what image comes to mind when one says sepsis? Is it as clearly appreciated as say, meningitis or pneumonia? I appreciate that sepsis is more complex, but can we do a better job at describing this? Let's examine the current definition that has been in use for the last 2 decades. Sepsis is documented or suspected infection with two or more SIRS criteria. These criteria are temperature, heart rate, respiratory rate, and white blood cell count. Septic shock is defined in 5 different ways, and any one of them can be used selectively in research. Let's now examine why these old definitions are problematic. Firstly, our current definition fails to make the distinction between a definition and clinical criteria. It provides a tool to detect sepsis without telling us what sepsis is. Much new information is available, and that needs to be incorporated into a clearer definition. Secondly, our current model is misleading because it suggests a continuum. We know that a patient's initial presentation may be in septic shock. An Australian and New Zealand ICU study found that 1 in 8 patients with infection and organ dysfunction did not have 2 or more SIRS criteria. Patients with sepsis often present with high spiking fevers, shock, and respiratory failure. And for many years, we believed that it represented an uncontrolled inflammatory response. Current evidence suggests that both pro-inflammatory and an opposing anti-inflammatory response occurs concomitantly in sepsis. More than 70% of deaths in sepsis occur after the first 3 days, with many deaths occurring even weeks later. Postmortem studies reveal that 80% of patients who die from sepsis in the delayed phase still had foci of infection despite broad-spectrum antibiotics and source control. And this suggests that many patients do not eradicate their infections and develop secondary hospital-acquired infections. It is felt that improved treatment regimes have resulted in a disease shift away from the initial hyperinflammatory phase to the later hypoinflammatory or immunosuppressed phase. SIRS criteria were intended as a wide net, and the high sensitivity falsely includes far too many patients as septic. Therefore, a high percentage of ICU patients in the US, Europe, and Australia and New Zealand would qualify on the basis of 2 or more SIRS criteria. This low entry threshold results in a dramatic increase in less sick patients being included in the overall prevalence of sepsis, and a parallel deceptive reduction in mortality. Now, of course, we all understand that it is statistically significant that our Australian colleagues are much better at managing sepsis than their European counterparts. However, a 40% difference underscores why proper definitions and criteria matter. The challenge facing the Sepsis 3.0 team was how can we improve the definition of sepsis so that it can satisfy multiple domains of usefulness, helpful to clinicians, researchers, and policymakers. Can we describe sepsis in a way that better describes our current understanding of the disease? Can we differentiate sepsis from uncomplicated infection? And can we separate the definition from clinical criteria? We know that infection is the initial trigger that sets in motion a self-propagating cascade that drives the process. The host response is unlike the normal response to infection and involves both pro- and anti-inflammatory cytokines. This intense response eventually leads to organ dysfunction. Not uncommonly, organ dysfunction is the initial presentation, and infection and sepsis is a delayed consideration. The final result is an overall higher risk of dying. These factors resulted in the final definition of sepsis as life-threatening organ dysfunction that results from a dysregulated host response to infection. Since the definition includes organ dysfunction, the previous category of severe sepsis becomes redundant. The current definition of septic shock is based on blood pressure and hemodynamics only. How do we better define septic shock? Is it all about the cardiovascular system? Whilst blood pressure and the heart are important, the shock state in sepsis involves cellular and metabolic pathways. Does the management help differentiate? We manage septic shock as aggressively as we manage sepsis. Is it possible that the pathobiology is different? Well, we don't really know. But what we do know is the one thing that distinguishes septic shock from sepsis is mortality. And therefore, we can define septic shock as a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. New definitions are good, but of what practical utility is it to clinicians? How does one identify a dysregulated host response, an organ dysfunction? If we were granted 3 wishes in this regard, what would we wish for? We could wish for a diagnostic laboratory test or a screening tool that will either rule in or rule out the diagnosis. The absence of these puts that idea up in smoke, so to speak. But fortunately, we have one wish left. And because we know that patients with sepsis are very sick and at high risk of dying, could we wish for a global risk stratification tool that is based on clinical criteria that could be easily done by the triage nurse and perhaps obviates the need for any laboratory tests? We know that sepsis is predicated on infection. So, amongst those with infection, can we pick out those patients who are really very sick, i.e., those that are most likely to be truly septic? Now, an evidence based approach was used to examine the records of 1.3 million hospitalized patients. 149,000 of these had infection, and this group was divided into two: existing clinical scoring systems such as the SOFA score, LODS, and SIRS were applied as to validate them in one group and then used to determine predictiveness in the other. Furthermore, a set of 21 other clinical and laboratory criteria were also applied to see if these could provide any new method that may be useful. In this way, they were able to find those patients who were most likely to die from their infections or have a prolonged ICU stay. The results showed that in the intensive care unit, SOFA and the more complex logistics organ dysfunction system came out on top. Outside the intensive care unit, SOFA and the newly coined QSOFA prevailed. From this slide, it is clearly evident that LODS is more complex than QSOFA or SOFA. So it was decided to go with the latter two. The SOFA score has clinical, laboratory, and treatment criteria and is best remembered if one considers a system-based approach. In the central nervous system, we consider the Glasgow Coma Scale. In the cardiovascular system, mean arterial pressure and the use of vasopressors. In the respiratory system, we consider the PF ratio. In the hepatic system, serum bilirubin was considered as this was more regularly checked rather than INR. For the renal system, we look at the serum creatinine and urine output. And lastly, we consider the platelet count. One would still have to plug in the information into the scoring tool to get a result. To be valid, we need a change in the SOFA score of 2 or more points. This would account for patients with pre-existing problems such as renal insufficiency. However, the major criticism is that one has to wait about 6 hours to repeat the test. There has been suggestion to assume a baseline score of 0 in all patients to expedite detection of organ dysfunction. But this has not been prospectively validated. Recall that the best we could wish for was a global risk assessment tool and not a screening tool. QSOFA is one of those tests that picks out patients at triage who are at the most risk of dying. Systolic blood pressure of less than 100, altered mental state, and a respiratory rate of greater than 22 make up the QSOFA score. If none of these are present, mortality risk is less than 1%, whilst a score of 3 imparts a 20% risk. Again, the major criticism is that there is no prospective validation. We've already established that the single factor that discriminates septic shock from sepsis was mortality. Therefore, it's logical to look for those clinical criteria that have the highest mortality. The mortality, if the lactate alone was greater than 2, is 25%. If fluid refractory hypotension and vasopressor use is still ongoing, then that mortality is about 30%. However, if all 3 factors are present, then the mortality risk is 42%. To diagnose septic shock, we have to adequately fluid resuscitate in the first 3 hours and recheck the serum lactate at the 3-hour mark. And if all 3 criteria are present, only then can we call this septic shock. Let's illustrate this with an example. If a patient presents with a lactate of 3.8 and is adequately fluid resuscitated, and at the 3-hour mark, the patient is on vasopressors and the MAP is now 55, but the lactate is 1.7, this is not septic shock. The committee intended for the criteria to be tight. So how do we operationalize all of this? We can apply the QSOFA tool to all sick patients in triage. If the score is 2 or more, then we should actively look for organ dysfunction. And this will include doing a serum lactate. If our screen for organ dysfunction is positive, then we can confirm a diagnosis of sepsis. If the QSOFA score is less than 2, and we still have a high index of suspicion for sepsis, then we can check for organ dysfunction regardless. If an alternate diagnosis is more likely and there is no evidence of organ dysfunction, then we can observe those patients more closely. For those patients diagnosed with sepsis, we can start fluid resuscitation and antibiotics and recheck the serum lactate at the 3-hour mark. At this time, if despite adequate fluid resuscitation, the mean arterial pressure is less than 65 and we require vasopressors to maintain our blood pressure, as well as the 3-hour serum lactate is greater than 2, then we can diagnose septic shock. Lastly, I'd like to look at two other tools that may be used in diagnosing sepsis and septic shock. The National Early Warning Score is a British scoring system which holds much promise and is undergoing current validation in Britain. In a retrospective review of 36,000 charts at a Chicago hospital, news fared better than QSOFA or SIRS. However, again, this was not prospective validation. Lastly, I would like to introduce you to the New York Hospital screening tool. This is a simple tool, and many emergency room physicians like to use this, and you will notice that it does include SIRS criteria. Whilst we try to validate SOFA and QSOFA as screening tools, many people feel that this may be a good transition measure. And I guess we'll have to just wait and see. Well, thank you, and I hope that you found this talk interesting and helpful. Thank you.